Today, we'll be asking questions about understanding MGUS, its progression, risks, and more. We chose this topic because in talking to MGUS and smoldering myeloma patients, there's always hope for peace of mind regarding if they'll develop active myeloma or not. And if so, is there a predictable timeline, or is there anything patients can do to decrease their risks of the progression? To answer those questions and to give us more insight, we invited Dr. Khan to join us today. Dr. Khan earned his medical degree and special distinction at the University of Michigan in Ann Arbor, Michigan, while also obtaining a master's degree in public health from Harvard. He performed a residency in internal medicine at the Cleveland Clinic and Lerner College of Medicine in Cleveland, Ohio. After serving as a hospitalist at Massachusetts General and an instructor at Harvard Medical School, and concurrently obtaining his master's degree in epidemiology from Columbus University, he gained advanced training in hematology and oncology through a fellowship at Beth Israel Medical Center and Harvard Med School. He is currently an assistant professor of medicine and public health at UT Southwestern, where he serves as the director of myeloma epidemiology research and clinical director of monoclonal gammopathy precursor clinic. And with that, I'd like to turn the time over to Dr. Khan.
Thank you so much, Cindy. Let me share my slides here. Obligatory question. Can everyone see my slides?
Yes, they look great.
Great.
Thank you.
Well, thank you so much for that introduction, and thank you all so much for your attention here today and for spending your lunch hour with me. It's my pleasure to be presenting to you about MGUS and to be talking about it within the context of some of the more broader monoclonal gammopathies, as they're called. This will be a little bit of a tour de force. We're going to try to bring in a lot of, I think, relevant detail related to things that patients actually ask me in clinic. And so I hope to make this interesting, definitely relevant, and to give anyone who wants even more than just a lay understanding a little bit extra too. So I'll be trying to talk at sort of different levels here. This is a list of my disclosures. And what I'd like to quickly begin is just like, what's a typical case of MGUS that I see in clinic and how it pertains to then you all as a patient. Let's say there's a 73-year-old man who comes to hematology oncology because of some abnormal labs that a primary care physician drew. Some things on the past medical history there, sort of the usual things. Maybe he has asthma, maybe he has acid reflux, heart disease. Let's say he's on omeprazole, aspirin. These are all common things. Nothing jumps out too much in the family history or the social history. And on those labs, and as it has become more commonplace to share one's labs, you can usually see one's labs on a portal at any health system. This person had a total protein elevation. And that's what then led to a serum protein electrophoresis, one of the mainstay lab tests that we draw here. And on that serum protein electrophoresis, and I'm going to go more into what that is and what that means, they found a monoclonal protein, an M protein, or an M spike, or a paraprotein, a lot of names for this entity. And in this case, it corresponded to an IgG kappa. And of course, it's a natural question for you, the patient, to ask, well, what is a monoclonal protein? What is a paraprotein? And what does this all mean? And let's say before that's even answered, more tests are ordered. And let's say there's a PET scan that's completed. And patients always ask, what does a PET scan look like? And so I've included an actual one here. And let's see if this actually will play here. And this is actually an entirely normal PET scan. And so as you can see it runs cross-sectionally through the body, starting at the top of the head down to the feet. The right side is actually on your visual left. The left side is on your visual right. And there's a full body representation of it on the screen here on the right side. This is a normal PET scan. This is what we're always talking about right here in front of you. And then let's say the radiology report agrees that it's normal. And let's say things go as far as a bone marrow biopsy, and this is where things start to then get interesting. That's performed here, and on that, The key line, which I've highlighted here in the blue here, is that there were 5% plasma cells on the examination, and the broader plasma cell population still remains under 10%. Cytogenetics finds some small aberrations here, but nothing that we would consider necessarily high risk. And so what is this? Well, that's the topic of our discussion today. This is monoclonal gammopathy of undetermined significance. To be clear, this is not myeloma, smoldering or active, nor is this another monoclonal gammopathy. The key lines for why that is the case is down below. I'm going to delve a lot more into this so that you all can absorb an understanding of why this is called what it is and what we do about it. And so with that, I'd like to then just say that I know you all always have the same questions of what is MGUS? Why is it called undetermined? Why is it multiple myeloma? Why do we call things smoldering myeloma? What is the cell that's involved? What's really going on with these proteins? All common questions are all very important questions. And so I'd like to quickly start with the historical portion of this, of like why things are the way they are, why are they called what they are called, and what does that then mean? So MGUS is tied to multiple myeloma. That's the real concern from that. And the first known case of myeloma that we really have published comes around the 1840s in Europe, where a woman who on autopsy had severe fractures and these tumors in the bone marrow. And so on autopsy done by Sam Solly, he found that these were just large material masses there. And later, this was then renamed multiple myeloma by another European physician, Dr. von Rostitsky, who came up with that name because myelo refers to marrow or spine, and oma means tumor and masses. And because this unfortunate lady had multiple of them throughout the body, leading to those fractures, the name became multiple myeloma. This is the actual original publication that led to that here, screenshot. And that name has stuck really ever since. Now, it predated what anyone knew about the M protein, as we call it now, or plasma cells. That came later. And plasma cells were discovered by a different European physician, Dr. Heinrich Wilhelm Gottfried Waldeyer Hartz, who saw these very large cells that I've shown here among red blood cells, and he called them plasma cells because they had a lot of cytoplasm. This is the nucleus of the cell. This is the cytoplasm. Because there's a lot of it there, it was simply named as a plasma cell. What came later was the recognition that there was something called an M protein. This is where Benson Jones discovered that in the urine, and it was more characterized in the urine than it was in the blood because it was more easily crystallizable out of the urine than it was the blood. Blood being a more complicated substance, this is the 1800s, it was harder to do so. And so these cases of multiple myeloma were characterized by this abnormal protein, this monoclonal protein found in the urine. And again, as I said, later that we found in the blood. The tie that we then see to the cell that was guilty for all of this is here on the bottom here, a plasma cell. All blood cells are made in the bone marrow, and they're made by stem cells. And stem cells have two big paths that they can go down. There's the myeloid path and the lymphoid path. Despite how confusing the name is, the myeloma-related cells, the plasma cells, come from the lymphoid path. Myeloid here refers to the fact that, again, myeloid is bone marrow. And so this is where there's some confusion in terminology, but this is where it all starts. On the myeloid path is where most other white blood cells are made, red blood cells and platelets. And on the lymphoid path is where we have our B lymphocytes, T lymphocytes, some other cells called natural killer cells, and then plasma cells. Plasma cells are B lymphocytes that grow up fully. And so the realm of monoclonal gammopathies and MGUS specifically is within this realm, from B lymphocytes to then particularly plasma cells. And so plasma cells are a normal part of our bodies. They are responsible for making antibodies. They're not the only cell that makes antibodies. B lymphocytes, as I said, also do so. And when plasma cells become a little altered, they don't stop making antibodies, they make abnormal antibodies. And that is what is detected as monoclonal proteins, as an M spike, an M component, or as a paraprotein. And depending upon how what the quantity is and what the situation of it is, that's where on the spectrum of monoclonal gammopathies, someone would land. But in all cases, it is tied to some misbehaving cell along the line of a B lymphocyte or a plasma cell. And so, what is an antibody? What does it look like? Why do we speak of the chains, the heavy chains and the light chains? So, antibodies, again, are normal proteins within all of us. Their job is to help us fight off infection. A 3D structure representation of it is here on the left. And we usually kind of draw this cartoon in every medical setting where an antibody has two heavy chains, that's shown in the blue here, and then two light chains. Of the heavy chain types, there are five that are possible. There's alpha, delta, epsilon, gamma, and mu, all Greek letters. And with the light chains, there are two possibilities, kappa and lambda. And depending upon the heavy chain type, that is where then we have these full antibody names of IgA, IgD, IgE, IgG, and IgM. And because there are two light chains, we then have 10 possibilities. IgA lambda, IgA kappa, IgD lambda, IgD kappa, et cetera, et cetera. Most commonly with MGUS, we are speaking of IgG, IgA, IgM, and then free light chains alone. And so the terminology of this is where I think there's a lot of a stickiness. Why is it undetermined significance? Well, it wasn't always called that. It used to have actually a number of different terms. In the 1950s, Jan Waldenstrom of Waldenstrom macroglobulinemia had coined different terms to it. There was benign monoclonal gammopathy, essential hyperglobulinemia, and these were vague terms, but they were meant to describe patients who had that M protein that they particularly found in the urine, but they didn't have features of myeloma or what we call Waldenstrom macroglobulinemia. They didn't seem to have clinical trouble, but they had this M protein there. And Dr. Bob Kyle, who was at the Mayo Clinic and a contemporary of Jan Waldenstrom, later renamed this as monoclonal gammopathy of undetermined significance, basically acknowledging that these people are not necessarily going to have a benign course. There are some people who progress to having clinical trouble, i.e., they can have some of these blood cancers. And that's where the undetermined portion of it came. He is also the one who coined smoldering multiple myeloma. And so we credit him, and he's still alive and kicking today at Mayo, for crediting those terms. And we're going to delve a little bit more into that. Overall, I'd like to just step back and say, well, within the context of MGUS, looking at thin myeloma, just how common is this really? And we're going to spend more time about it in a moment. Overall, myeloma is considered a pretty rare malignancy. Usually the big four in developed countries are colorectal cancer, breast cancer, prostate cancer, and lung cancer. Myeloma represents about 1 to 1.5% of all new cancer cases in the US, and that incidence has been relatively steady. Now, I will say the prevalence of myeloma over the past 1 to 2 decades has certainly increased, but that is a reflection of the fact that fortunately we're keeping people alive longer and well longer. And so the prevalence has risen, even though the incidence is relatively constant. It's really a marker of success. And so then when we talk about where does myeloma and MGUS all come in, well, it's all about the definitions that were set back in the 50s, 60s, and 70s. Real quick, not going too much into the weeds here, but just a little bit, and then talking more about it in parts. Monoclonal gammopathy of undetermined significance is really the presence of an M protein. That's it. As long as we can measure it, as long as we demonstrate it's there, that defines at least having MGUS. When that M protein becomes too much, I'll put in quotations, or the cells that make it become too much, that's what was defined as being something different. It's a little bit of an arbitrary distinction. And again, that was what was chosen in the 1960s and 70s and what we've held on to, but it's a little bit artificial. And those criteria are greater than 10% plasma cells in the bone marrow. Normally plasma cells are usually 2 to 3%. So greater than 10, we consider that's too much to say just MGUS. That's what we've then called smoldering myeloma. We say then if the serum M protein is greater than 3 grams per deciliter, say that's too much for just plain old MGUS, that's called smoldering. Or if in the urine, there is more than 500 milligrams per 24-hour period of M protein, what's often renamed Bence-Jones proteinuria, that's again considered too much for MGUS. That's what's then smoldering myeloma. And then the difference between smoldering myeloma and what we simply call multiple myeloma or active or conventional myeloma, basically what we need to treat, is then the presence of clinical misbehavior. And those are cardinally what's affectionately called the CRAB symptoms: calcium issues, kidney issues, anemia, bone lesions. The cartoon on that is here. And so the CRAB criteria is what was really set by Dr. Bob Kyle again in the 60s, 70s. And then more recently in 2014, there was a paper that added what we call the SLIMs to this, also called myeloma defining events. So now we talk about SLIM CRAB criteria. The SLM refers to 60% or more plasma cells in the bone marrow. We then say that's even too much for smoldering. We then call that active myeloma. If a light chain ratio is greater than 100, there's actually a little bit of controversy of that nowadays. But if the kappa lambda ratio, which we're going to talk a little bit more about, is too far above normal, then we consider that even more than smoldering. That's considered active. Or if there's an MRI demonstrated lesion of 5 millimeters or more, at least one, then we consider that to also be active myeloma. And then the CRAB features remain as they are of hypercalcemia, high calcium, renal impairment, anemia, or bone lesions. And to be clear, when we're speaking then of MGUS, you have none of these features by definition. In general, MGUS has been historically broken down into three very broad types. There's been more nuance to this that's been added, but often we've spoken about non-IgM MGUS, which often is then referring to IgG primarily and IgA secondarily, then IgM MGUS, and then light chain MGUS. The most common isotype out there is the IgG type. And to be clear, as we said earlier, MGUS is not always from plasma cells. B lymphocytes make antibodies as well. They can also be what's implicated. And so actually, when we talk about IgM MGUS, we are not so worried about risk of progression to myeloma in that case. We actually talk then about risk of progression to something called Waldenström macroglobulinemia, which is really a lymphoma. These are all within relatively the same family. And so don't let the terminology make you think they're so different from one another, but it's to reflect that there are these sort of boundaries between them. In general, about 17% of all MGUS is of that IgM variety. And again, that's where we're not concerned about myeloma progression, even though it has been described, it does exist, but it's exceedingly rare. We talk more about a lymphomatous progression in that case. So in general, where does then MGUS sit on the spectrum of cancer? Like, is it a cancer? That's one of the very common questions that I get. And the answer relies on the fact that cancer is not such a yes-no matter. In general, there's something called the multi-hit hypothesis, where we believe that in cancer formation in humans and mammals, there's a situation where cells become increasingly abnormal by increasing hits. And that's what marches them along from being benign to then malignant. And so if you take a normal tissue, and I'll make parallels to other cancers in a second. It'll take one alteration and a second and a third, even in ways that we may not understand, that finally makes something then abnormal enough to call cancer. So MGUS is not truly normal, but we don't consider it a cancer. Then multiple myeloma is certainly a cancer, and smoldering is somewhere in the middle. And so where things stand is, again, a little bit arbitrary. This is to reflect, though, that it's a spectrum. The parallel that I like to often make is like a colon polyp. You know, a polyp is just a polyp, but it can become a colon cancer. And where is it along the lines that you say that one thing is truly benign versus one thing is truly malignant? Well, it's not as simple as that. And I like that parallel as well. So there's a steady creep from MGUS to smoldering myeloma and myeloma, even in ways that we don't fully understand. So is it a cancer? We don't consider it to be so. We consider it to be precancerous. This brings me to something then that in cancer biology has been talked about for a long time, which is the affectionately named hallmarks of cancer. This is a landmark paper in cancer biology published originally in 2000 with an updated list in 2011, and basically talks in broad terms about what are some of the cellular features that cancers tend to share. And what we have seen then is from what was originally 6 to now 10, there's this suggestion that in the case of MGUS, probably what is happening is that more and more of these hallmarks are being accrued, and hence why MGUS would march along more towards the cancer spectrum. So this is that spectrum. So this is the spectrum monoclonal gammopathies with the definitions underneath them. And you have benign on the one hand, malignant on the other. And since I came from Boston, this is what I'll show. Um, but in reality, it's always more complicated than that. And our terminology never really fully fits the biology. So from this more simple model, MGUS, smoldering myeloma, and active or conventional multiple myeloma, there are a lot more entities within there. There's, again, smoldering myeloma, which has actually very, as we've increasingly learned, very different prototypes. When we risk stratify people, they have very different courses. Um, there's Waldenström macroglobulinemia anemia. There are these sort of in-between states of monoclonal gammopathy of clinical significance, what are called paraneoplastic syndromes, like POEM syndrome, and other situations like amyloid and deposition diseases. And what I sort of like to tell people is MGUS, we say, is really here, and everything else here you can kind of call monoclonal gammopathy of determined significance. This is the undetermined significance, and then this is the determined side. And there are some actually quite rare entities here. And so the main ones still are MGUS, smoldering myeloma, multiple myeloma. And when we then talk about, again, where things fit along the cancer spectrum, at what point is something then hot enough, when it's smoldering enough that we actually then treat? And do we screen for these earlier lesions? What do we do about the whole situation? So in starting to answer that, well, how common is MGUS? It's a very good question to ask. And this is data that comes then from the Mayo Clinic, where in previous studies, for more convenient samples, not truly population-based samples, the prevalence of MGUS was somewhere around, 0.5 to 4%. And these are some of the studies listed here. But there was a population-based study that came out of the Mayo Group, Olmsted County, Minnesota, published in the early 2000s, where they approached then upwards of 20,000 patients of age 50 and over to more properly answer that. And what they then found was that the overall prevalence of MGUS in their situation was 3.2%. And they saw that men had it more than women, and it increased with age. These are all things that we've now seen in numerous studies. And from that, then I'd say the best study that we've had now is what's called the ISTOP-MM study. This came out of the International Myeloma Foundation's Black Swan Initiative, and it stands for Iceland Screens, Treats, or Prevents Multiple Myeloma, and has been run out of the University of Iceland. And this is a study where they basically took the entire population of Iceland, screened those who were of a certain age or older, offered then 81,000 to, offered 150,000 to participate, 81,000 consented, and over 75,000 provided blood samples. So a massive amount of data. Now, I acknowledge that the population of Iceland is a little bit homogeneous compared to others, so you can't always say that what we see in certain other populations, let's say here in the US, it necessarily applies from what we see there, but this adds to the growing body of knowledge of MGUS and related monoclonal gammopathies. And in this, they had different ways that they monitored people in different aspects to what they are looking at. And what they found in relation to MGUS is that they saw that IgG is the most common. That's what we know of. IgM secondarily, then IgA, and they didn't speak in this particular paper about the free light chain MGUS. And the overall prevalence that they found of MGUS was about 4.5%, very similar to what we saw of the 3%, roughly 3% of the Olmsted County Mayo data. And in general, we've now come to say that overall, above the age of 50, the general prevalence of MGUS seems to be about 3 to 5%. What they also did was in a different publication, they compared what they called clinical MGUS versus screened MGUS. So those that they went out looking for versus those that more incidentally came to them, roughly said. And there, as you might imagine, those that they're screening for, they found with a little lower M protein concentration, they were a little bit younger, but overall very similar. So when we find MGUS, sort of regardless of situation, it seems that we are usually talking about something quite similar. I'd like to make a plug then and acknowledge two other very important studies that have come out of the Dana-Farber group that have also looked at MGUS and are ongoing. One is the PROMISE study that's geared towards African Americans and those with a first-degree family member who may be diagnosed, and the P-Crowd study for patients who are already diagnosed with MGUS or a related precursor hematologic condition. PROMIS, P-Crowd, and iStop-MM have really offered us a lot of information in really just the past few years about monoclonal gammopathies overall. And one thing that we know of from historical data and certainly from them is that there's some interesting racial ethnic disparity in MGUS and other monoclonal gammopathies. This study is from 2014, and it took the National Health and Nutritional Examination Surveys samples and basically performed serum protein electrophoresis on them to see what's the prevalence of MGUS and what was at this time the broadest national sample. And there they found an overall prevalence of about 2.4%. But what they found that was more interesting, and this was the purpose of the study, was that there was a lot of difference in the racial ethnic groups here. So they saw that Blacks had more monoclonal gammopathy of undetermined significance than whites, and whites more so than, in this case, Mexican Americans. We know for some other data that different other Hispanic and Latinx groups actually maybe have higher rates of monoclonal gammopathies, but that was not what this study was able to address. And overall, you can see that men have more than women, and the overall prevalence increases with age. And that's what these curves also represent here. So we see Blacks more than whites, more than Mexican Americans, more in men, more than women, and more as people got older. And those are the kind of the summary details here. So again, MGUS present in about 3 to 5% of the population above the age of 45 to 50, much more common in Black Americans than white Americans. By some data, it may be that 17% Black Americans may have a monoclonal gammopathy. And while the overall rate of progression from MGUS to myeloma, we usually quote as 1% per year, it seems to be about 3 times higher in those who are Black American. So in a different set of studies, the question was asked, well, what if we look at not African Americans, but Africans? Is there something truly genetic going on, or just something about the African American experience that may be different? And this study was run out of, in part, the Dana-Farber group, where they approached Black Africans in South Africa and took samples there and ran serum protein electrophoresis and, mass spectrometry in this one. And they found that the overall MGUS prevalence was about 12%. So that's a bit higher than what we had seen in the NHANES example here. But they did see the similar pattern here, that they saw IgG as being the most. And then here, IgA and IgM were a bit lower, but in a pattern that we expect. And just for a moment to compare that to then myeloma, actual multiple myeloma in an African example, comes from a Ghanaian tertiary hospital. So this is a different population. This is more for illustrative purposes. They saw that the median age of diagnosis is 58 versus it's in the 70s here in the US broadly. And the overall median survival there was 33 months. Here it's over 8 years. And so it speaks to maybe there's something that we simply don't understand that those of more recent African heritage have that predisposes them to these monoclonal gammopathies in a more potent way. A lot of work still undergoing on this to try to address that disparity and what can be done about it. Now, the progression of MGUS to myeloma, as I said, it's usually quoted as 1% per year, and that comes also from Mayo Clinic data. That is the Olmsted County broad data. This is where they looked at 1,300 patients from over a 3-decade period. As we've tried to add more nuance to that, there are different other models that have come about to say what are people's risks for progression from MGUS to myeloma or something beyond. There are several out there. I'd like to highlight one, which is the Pangea model, which came from the Dana-Farber group, and it's had other validation studies elsewhere. And it's a website. You could actually access it yourself. You plug in basically the parameters that you would have from blood work and potentially bone marrow biopsy. And it gives a rough estimate of what someone's progression from MGUS to something beyond would be. The red is what that rate represents here on the graph here. And the gray bars are basically confidence intervals. And as you can see, as your time goes on, we're less confident in that prediction, which makes sense. And this is just one of, again, several models that can be used for MGUS. One of the more classic ones that we use is based on the Mayo data that simply designates people as low risk, intermediate risk, or high risk. And that's what's still often used But I highlight this to point out that there are other models out there. And in general, for MGUS, the guidelines are a little bit mixed. This is from a 2018 paper. Um, and since that time, because there's been so much updated data, there really isn't a great international standard. There are just generalities. And over time, more will be consolidated as we come to understand more. A general rule of thumb for follow-up of MGUS is every 6 to 12 months, vaguely speaking. But again, nuance is really what's key here. And I ultimately advocate that you should have a conversation with your physician about how you should be followed up based on your particular scenario. And so how do we then manage it? What do we do? And one of the questions I always get is about bone marrow biopsies. Do we have to do it? What's the point? And who should get one? The simple answer to that is that there's no clear best answer. What we used to say was that for uncomplicated MGUS, typically of IgG isotype, nothing else going on, like no unexplained anemia, no unexplained kidney issues, with a low level, quote unquote, M protein, bone marrow biopsy was not necessary. We still largely use that. But we have increasingly acknowledged that as we've done more bone marrow biopsies and more invasive studies in patients, of course, we see more stuff. And so we're trying to figure out exactly where to place people. One attempt at that has come from the iStop group, where they came up with a bone marrow biopsy calculator. It's really a prediction model. And it takes the measurements that you would get from a conventional set of blood tests from the SPEP and gives a number that represents what's the probability that you might actually have smoldering myeloma underneath. This is to be clear, this is so kind of in its beta version, it has not been externally validated yet. It's certainly not perfect. And at least for me, as someone who very much spends a lot of time in this field, it seems to always confirm my intuitions, which I appreciate. And it represents, again, our attempt to come up with something more precise of who to marrow, who to not. And again, I ultimately say that it's a conversation you should have with your provider about. Coming back to then the test that really starts all this, the protein electrophoresis. I want to just delve a little bit more into that, what that is. Serum protein electrophoresis or urine protein electrophoresis is not an old test, excuse me, not a new test. It's over about 100 years old. And it's where they take a sample of either blood or urine, put it on gel, and run a charge across it. And that then separates all the millions of proteins in that given sample, some of which may well be undiscovered, and it separates them into largely 5 buckets. The main bucket, the biggest one, is always albumin, which is the main protein in the blood. And all these other proteins we call globulins. And we call them alpha 1 globulins, alpha 2 globulins, beta 1, beta 2 globulins, and then gamma globulins. Gamma globulins are where the antibodies that we are concerned about live. And these are some actual SPEP examples here. When we see an M spike, what we see is not like this normal pattern here of nice large albumin spike and then kind of the typical humps for alpha 1, alpha 2, beta, and gamma. We see this. We see a huge spike in the gamma region. That's exactly why it's called an M spike. This is what is seen, and that's where the name then comes from. And when this has been immunofixated out, that's where we can type what actually that M spike is, its identity. This is an example of what those gels look like, and this is what we see behind the scenes. Now, as I said, this is not a new test at all. This is actually quite old, and it's still been the standard. It's still largely the standard today. But increasingly, we now have a new kid on the block, which is mass spectrometry or simply mass spec. And this has been used really by specialized centers, and it's just a much higher resolution way to look at proteins in any given sample or other chemical substances. And because of the resolution, we have now seen a lot more with mass spec. And in this paper that where they performed mass spec on almost 20,000 cases, roughly speaking, they found about a third more M protein than they did by just conventional SPEP alone, reflecting the fact that as you look more with more sensitive tools, we tend to find more things. To be clear, mass spec is not as widely available clinically. It's mostly again at specialized centers, but it is something that's being used increasingly more and more. And in talking then about risk factors for MGUS, like who progresses and why, what has been established, and this is a 2021 systematic review, and the data really has not shifted from then to now, is that the main risk factors, number one, still remains to be age. Older people have more monoclonal gammopathies, including MGUS, than younger people. Sex, males more than females, and then race ethnicity. As I said, blacks more than whites. Again, Hispanic populations, a little bit mixed. Some have more, some have less, and Asian populations seem to have the least. Then other more possible risk factors, which are not as well established, but there's some support, but then there's some controversy to them, is that immunocompromising conditions, such as potentially HIV and others, inflammatory and autoimmune conditions, there is a relationship that we see, but it may be soft. Then there are other things like smoking and diet and obesity that may be related, may not be. In terms of how this maybe ties to progression, that is very much ongoing work. There are a lot of my colleagues nationally looking at different things from dietary and other lifestyle modifications to other factors that might be tied to interventional ideas for progression from MGUS to beyond. But to be clear, we don't have any answer to that yet. And so why does MGUS occur? It's something that patients always ask. Why does this happen as people get older? Why is it there? And the short answer is we don't know. But what we seem to find in about half the cases is some alteration to certain genes. The heavy chain gene, the gene that makes the heavy chain part of the antibodies, seems to have some alteration to it in about half of cases. And this may well be random. Again, there seems to be more to that based on what we've seen by the fact that some groups have more than others, that first degree family members have more than others outside the broader population. And so this is where a lot of work continues to be done. So no more to come on that, I hope, in the coming years. And then back to our spectrum monoclonal gammopathies, I want to then just talk very quickly about smoldering myeloma, because that's what we patients are often very concerned about, and then a little bit about what are called the MGCSs, and that will then suffice my talk here. Um, Smoldering myeloma is sort of the black box here because whereas in active conventional myeloma, people usually have signs and symptoms that bring them to attention. And MGUS is a little bit more, as we said, we tend to see a little bit more incidentally. The middle ground there of smoldering myeloma is kind of the grayest because you would have to have a bone marrow to have it diagnosed, and a lot of people simply don't have that done. Again, that may be changing, but that was what was historically the case. But overall, of all patients with myeloma, this is national data from the US, this is from a 2016 paper, of about 90,000 patients, about 14% were deemed to be smoldering myeloma. And in the iStop-MM study, in their estimates of what smoldering myeloma's prevalence is, they came about with about 0.53%, which was quite a bit higher than I think a lot of us expected. This is saying that roughly 1 in every 200 people in their sample had smoldering myeloma. That's quite a bit more than what we many of us anticipated. And the amount of M protein that they had for that was really not that high by many estimates, 0.62 grams per deciliter of M protein. Again, I should remind you that the iStop-MM is a very homogeneous population, may not be as applicable to others, but this is something that has led to more and more investigation. And what they did see, and this is again true of all monoclonal gammopathies, is that there's an increasing incidence with age. The overall prevalence then, excuse me, the progression from smoldering myeloma to then active myeloma is quoted as roughly being 10% per year. And who is high risk, who is low risk? And then from MGUS, that's where people have a lot of concern. And there have been different risk models for that. And I will just highlight what is the 2220 criteria here for smoldering myeloma, where based on lab tests and the bone marrow biopsy, we can stratify people fairly well into 3 rough categories. And there's actually an updated model to this that includes cytogenetics, but I'm including the earlier version here, where if someone has greater than 20% plasma cells in the bone marrow, an M protein in the blood greater than 2 grams, or a free light chain ratio, that kappa over lambda number of greater than 20, that separates out people into these categories. Low risk if you don't have any of those features, intermediate risk if you have one, and then high risk if you have at least 2 of them. And you can see how these curves of then progression separate out very nicely. And over time, we have seen from MGUS to smoldering to myeloma that we have tried to understand more and more who is in fact going to progress, who does warrant earlier and more intensive monitoring, who doesn't, and again, more to come. Um, this is just some numbers attached to that paper, looking at the actual odds ratios for progression. In the interest of time, I'm going to accelerate just a bit here and come back to, again, the spectrum of monoclonal gammopathies, and just mention that there exists this entity of monoclonal gammopathy of clinical significance and other stuff here. Again, some rare entities, some funky entities, but I highlight it because when people have an SPEP checked, I always like to ask them, what was the situation that was checked? Was it to work up neuropathy? Was it some renal issues? Because that makes me, in the back of my mind, as someone who specializes in this, to ask, could there actually be not MGUS at play? Could it be maybe a monoclonal gammopathy of clinical significance? The most famous one here is monoclonal gammopathy of renal significance. And it's a situation where a patient has an M protein and they do not meet criteria for myeloma, amyloidosis, Waldenström macroglobulinemia, or another already defined entity. But that M protein on kidney biopsy seems to be misbehaving. So you can't call it MGUS because it's doing something, but you don't call it one of these other things because those have already boundaried definitions. So it kind of fills the space. And this is an actual quote to describe that. Um, and again, this is just one example of an MGCS. There are numerous out there. There's monoclonal gammopathy of neurologic significance, monoclonal gammopathy of thrombotic, thrombocytopenic significance, and so on. In all cases, I should cite that most of these are quite rare entities. And so if I just had to like flip a coin or roll dice and say, do I think that someone has an MGCS versus not? Already the answer is probably not, but I don't dismiss it because that's, again, why we do these workups, why we investigate what we do. And when we find things, that's what we try to address, and that's how we serve patients. MGUS is then taking a little bit more of a bird's eye view, is part of a whole spectrum and a whole family or a whole zoo of what we're calling precursor hematologic conditions. We have found a lot of these over the years, and they are different precursor issues to different cancerous and other precancerous situations. And there's a lot of terminology here. I'm glossing over it just to say that as the science has evolved, we have found more and more things. These are some of the key ones here. We're talking obviously about MGUS. I've made mention of MGCS, myelodysplastic syndrome, something you may have heard of, clonal hematopoiesis of indeterminate potential, and other entities here. There's a whole host of them. I'm not outside the scope of this topic, but I bring it up here just to note that there are analogs to MGUS for other conditions too. And in general, all of them seem to increase as people age. So it seems to be that as people's bone marrows age, some of these issues with misbehaving cells accrue more and more. Um, As a final point here, I'd like to highlight that we have clinical trials that are starting to look at MGUS. This is from clinicaltrials.gov, and it's a website where all clinical trials in the US must be registered, and many international ones are also registered. And there's been a lot of effort now by the National International Myeloma, Waldenstrom, and other monoclonal gammopathy related communities to try to understand MGUS more and more. And so I highlight that a few years ago, we would not have had this type of work done. This is all really from the recent advocacy and attention that has been given to MGUS. With that, I'd like to just quickly summarize that in the spectrum of monoclonal gammopathies, there is MGUS, and there are more entities than just smoldering myeloma and multiple myeloma. MGUS and smoldering myeloma are more common than what we once previously believed. Smoldering myeloma, as I mentioned, is a little bit of an artificial construct and a heterogeneous entity. People with very different clinical futures are all lumped within there. M proteins or paraproteins or M spikes are usually inert, but are sometimes problematic. And to be clear, most patients with MGUS will not develop a more advanced problem. And finally, I'd like to say that I recommend that most patients with MGUS see a specialized provider at least once to have this discussed. And with that, I'd like to acknowledge some of the support people who have helped us here with the monoclonal gammopathy precursor clinic at UT Southwestern. And then I'd, of course, like to thank you all for your attention today and to HealthTree for the opportunity to share this with you all.
Awesome. Thank you so much, Dr. Khan. We're a little short on time for questions, so we're going to try to get through as many as we can. Any that aren't answered, I will jot those down and try to send out some sort of an email referencing some of our different articles or different things like that. But again, thank you so much for that wonderful presentation. We have a few pre-submitted questions. We're going to rapid fire try to get through as many of these as possible. First is, how can you tell if MGUS is progressing to active myeloma? What type of labs are you typically looking for?
The usual labs that we do are serum protein electrophoresis, plus minus urine protein electrophoresis, free light chains, and quantitative immunoglobulins, and then a simple CBC and usual metabolic panel. And in all cases, what we are looking for is the M protein rising? Are the free light chains rising? Or is there the development of new unexplained anemia, high calcium, kidney issues, change in creatinine. And then if people have imaging, then we look specifically for lytic lesions, punched out lesions within the bone. Any of those are signals that there may be increasing misbehavior from MGUS to something more significant. And that's where we then do broader workup that includes then repeat bone marrow biopsy, repeat imaging to answer that question.
Okay, perfect. Thank you. Let's see. And this is a question that I've heard often. Is watch and wait still the best strategy for high risk MGUS and also for high risk smoldering myeloma?
With high-risk smoldering myeloma, it's become a much more active discussion within the community. There are there's actually several studies which have looked at treating high-risk smoldering myeloma, and with different regimens from lenalidomide, dexamethasone, daratumumab. That's a very different topic and a very controversial one. In general, with MGUS, because of what the population prevalence is, it's relatively common, about 5% of the population by the age of 50, and the rate of conversion being about 1% per year to something more sinister. Really, active surveillance is, in fact, the best thing to do. And again, the guidelines are a little bit diffuse on it, but roughly every 6 to 12 months with the blood work really does us a good service in keeping an eye on what the situation of someone's MGUS is.
Perfect. Um, this next one gave a little bit of a history, but I'm going to get just to the questions. A patient has been diagnosed with MGUS and has passed the 11-year mark. They're wondering if, since they're past the 10-year mark, what the odds of progression to active myeloma might be.
That's a great question. So, we have quoted based on the Mayo data that it's the rate of progression is about 1% per year. And within the realm of what the Mayo group looked at, it was roughly linear. So at 2 years, it was 2%, 3 years, 3%, and so on. But the curve levels off in ways that we don't fully understand. So there's not the implication that someone who lives 100 years, they're going to certainly have myeloma. It levels off, but at that tail end was where the data gets thinner, and that's where we don't know. So what I would say is that it's a favorable sign that this patient hasn't had progression in 11 years, and we're going to knock on wood and hope that that remains to be the case. Um, and I would still advocate that they monitor it nonetheless.
Perfect. This next one is just asking if there's anything that can be done for anemia and fatigue. What are your suggestions there?
So for one, if when we talk about MGUS, we talk about myeloma and we talk about anemia. Um, with active myeloma, if we're saying that the anemia is from that, that's criteria for treatment. So that's not smoldering myeloma, that's active, that's criteria for treatment. But in the midst of all this, we often find that, there are other reasons that people can be anemic, and we really need to be reasonably certain that someone is anemia is caused by the monoclonal gammopathy M protein to then make the implication that that it can be blamed. So often though in the workups, I will find someone who's iron deficient, in which case I supplement them with oral or IV iron, or someone who may have had a gastrointestinal bleed and hence they've lost blood, or someone who might have a low-grade hemolysis. They're breaking down their blood cells for completely different reasons. So in all cases, the key answer to that is for whatever the reason is of someone's anemia, addressing the underlying cause is key. And so with whenever I find anemia in someone who comes to me with an M protein, regardless of where they are within the spectrum, I do a workup for it because in addressing it, I may absolve them from having being considered as having something more than MGUS, if that makes sense. So what I would
Absolutely.
advocate for this patient is that they should go to the provider and ask for that workup, and that then can be addressed.
Perfect. All right, and we're getting to a couple in the Q&A real quick. We have a patient that participated in Dr. Urvi Shah's whole food plant-based diet study for 1 year. Um, when that ended, some labs were drawn by their local oncologist, and he acknowledged that I no longer have elevated immunofixation, or it was now negative. Um, while I can communicate with him and assume that it is a positive result, might it be something you could speak to the presence versus not and the hope or indication that may represent? I hope that's stated clearly enough. So basically, these positive results from that whole food plant-based diet, what are your thoughts on that?
Yeah. So for one, the work that Irvi Shaw is doing at Memorial Sloan Kettering is fascinating, looking at dietary and lifestyle interventions and how it would relate to myeloma and broader monoclonal gammopathies from progression to other aspects of those diseases. That data is still early. Much of it's not published yet. A lot of those trials are ongoing. And so I can't speak to what may be specifically seen yet because we simply don't have those publications. But what I would say is that, part of the reason why that study is being done is that we're hoping that we do find favorable changes. Um, and so maybe it's tied, maybe it's not. It's not clear. One can't really say. What I will say, though, is that there is data that we have, and this actually comes also from the Mayo Group, where we do see MGUS resolution in patients. It's by some estimates 1%, by some estimates even up to 4% of people. And
Wow.
this was looking at a little bit of a younger adult population. Um, so it speaks to why monitoring is just important. So for this patient, it may be possible that it would show up again on a later blood test. I don't know, and that's again why we monitor here.
Yeah, absolutely. I love the hope that something that patients are able to do, on the outside with their diet could potentially help. So
Mhm.
it'll be interesting to keep watching that
Be very
data
interesting to
as
see where
it
that goes. Absolutely.
unfolds. Exactly. Um, so next question is just as red flags keep popping up,
Mhm.
how can I identify when my oncologist should be intervening? I don't want to wait until my kidneys or other organs show deterioration. Are there things that you would suggest to a patient to be, keeping mindful of?
Um, Without knowing the specifics, what I would say generally is that, we keep a close eye on slim crab criteria. And so when we see even the approach of some of these matters, so anemia, for instance, we should be less than 10 grams per deciliter. But someone who's gone from like 13 to let's say 11, even though that doesn't technically meet CRAB criteria, that rate of decrease makes me say this person needs more monitoring. So what I would say is that based on what the actual specific situation is and what may be seen or not seen, the monitoring may just need to be more altered and personalized to that specific scenario.
Perfect. And I like the idea of just making sure you've got a good and open dialogue with your physician. If you
Mhm.
have questions, make sure that those questions get answered.
Yeah, absolutely.
Perfect. Um, And we are so close on time. I don't want to go over. I know there's loads more questions, so I apologize to those we haven't been able to get to. Again, I'm going to keep a list of them and we will get some of this information out in upcoming newsletters and take some of them as well and use them for future webinars. So with that, we want to thank you, Dr. Khan, for your time. Um, and if you'll Unshare your screen, I'll
Of
share, and we'll close this up. So thanks again,
course. Thank you all for having me.
of course. All right. It'll take me just a second to start sharing again. There we go. Okay, perfect. So before we go today, I just wanted to highlight how to connect your records in HealthTree Cure Hub. After creating a HealthTree Cure Hub account, you're able to electronically connect your health records from any facility into your profile. Once your records are connected, you can now view a comprehensive overview of your medical records, including diagnoses, genetics, lab results, and treatments, all within a single user-friendly interface. It takes only a few minutes to create the connection and start taking control of your diagnosis. On the screen, I have a link to sign up for HealthTree Cure Hub along with the email address for our amazing patient navigators who are available to help you in creating your account. I'll also include this information on how to enroll in our follow-up email. With the different studies that Dr. Khan mentioned, I'll also make sure that we link the PROMISE and the P-CROWD study, along with any other MGUS studies that I can find that may be relevant. So just want to make sure you guys have all of that information to keep driving progress forward. As you leave the session today, we would appreciate you taking the 2 to 3 minutes to fill out the brief study about your experience. Our next MGUS and smoldering myeloma session will be happening this fall. So be on the lookout for details in the near future. But here are a few more upcoming events that you may be interested in. Next Tuesday, August 20th, our immunotherapy group will hear about elranatamab, how it works, how it's being used, and how it compares to other bispecifics. On Thursday, the 22nd, our Black myeloma health community will be learning about managing stress and anxiety, techniques for myeloma patients and caregivers. August 27th, our myeloma caregivers will have the opportunity to hear about the benefits of a meditation practice. The link to sign up for these and other events may be found on the link at the bottom of the screen and will be sent out in the follow-up email within 48 hours. I'd like again to thank our sponsors, Adaptive, AbbVie, Genentech, Johnson & Johnson, Pfizer, Regeneron, and Sanofi. And finally, I just want to thank all of you again for helping us build a strong multiple myeloma community. I've added my email address to the slide, so please don't hesitate to reach out if you have any questions about HealthTree or any of our programs. I also appreciate all of you and hope you have a wonderful rest of your day. Thanks again, Dr. Khan.
My pleasure. Bye-bye, everyone.
Thanks. Bye-bye.